Hi, I'm Dr. Brian Koffman, a retired family doctor and the co-founder, Chief Medical Officer, and Executive Vice President of the nonprofit CLL Society, and I'm going to be presenting some of the most important research that was done in 2023. The paper I'm presenting now was presented at the International Conference on Malignant Lymphoma, and it was entitled, or it dealt with Liso-cel, which is a CAR T therapy for relapsed or refractory chronic lymphocytic leukemia. It presented the results of the Transcend CLL004 trial. And what was the bottom line? Liso-cel, its longer name is Lisocabtagene Maraleucel, is the CAR T therapy that's closest to approval for relapsed refractory chronic lymphocytic leukemia, small lymphocytic lymphoma, largely based on the Transcend CLL004 results that showed a high rate of uMRD, undetectable measurable residual disease, in both the blood and the marrow, with a duration of response averaging almost 3 years overall and not reached for the 18% that had a complete remission. However, the average progression-free survival was a little less than a year. Side effects, as expected, included cytokine release syndrome, CRS, and neurotoxicity, and they were common but usually mild and manageable. In the way of clarification, duration of response is defined as the interval from response initiation, when there's first a response, to progression or death, so it only includes those who respond. Progression-free survival includes everyone, including those who respond and those who don't respond. That's why the difference. Let's get a little background here. Patients have been failed by a BTK inhibitor, such as ibrutinib, acalabrutinib, or zanubrutinib, and by venetoclax. By both of those drugs, have few options and a poor prognosis. Cellular therapies, including CAR T, seemed largely agnostic to high-risk features and the number of prior treatments, and they offer a good choice for those with very few choices. Let's go over the results. 137 patients were leukapheresed. That's where they spin off the white blood cells to collect the T cells that will be used to make the drug Liso-cel. And of that 137, 117 actually received Liso-cel. 83% had high-risk features. The median line number of prior therapies was 5, ranging from 2 all the way up to 12, and every single patient had a prior BTK inhibitor. This was a tough group to treat. 18.4% had a complete remission despite that. The overall response rate was 42.9%. The uMRD rate was even better. In the blood it was 63%, and in the bone marrow 59.2%, very close. Note that this is much higher than the complete response rate, where all the nodes and spleen must shrink back to normal, which doesn't always happen due to scarring and stretching of the tissue. The median duration of response was almost 3 years. Duration of response was only measured in those 42.9% of patients who responded, I remind you. Progression-free survival was only 11.9 months, which reflects the average time for all until progression, including all the responders and non-responders. Cytokine release syndrome, or CRS, where the inflammatory chemicals that are released when their cancer is being rapidly killed by this type of immune therapy, was seen in 84.6%, but there were no deaths. It was all grade 1 or 3, so it was relatively mild. Neurological events were present in 45.3%, again with no deaths. But the CRS and the neurotoxicity did require treatment. 69.2% needed tocilizumab, which turns off those inflammatory responses, or corticosteroids. The rate of grade 3, which are very serious infections, low immune globulins, and prolonged low blood counts, were respectively 17.1, 15.4, and 53.8%. One death related to Liso-cel was due to hemophagocytic lymphohistiocytosis, which is a very rare blood disorder seen with profound immune dysregulation that can be brought on by this type of therapy. The one piece of good news is Liso-cel exhibited rapid in vivo, in the body, expansion and was detected in patients' blood up to 3 years after the infusion. So in conclusion, sadly, CAR T therapies have been less successful in CLL and SLL than in other lymphomas, likely due to the exhausted T cells and the generally impaired immunity seen in CLL. Still, Liso-cel works very well in some tough-to-treat patients, but it is yet to be determined whether the average time to progression of less than a year will be enough to convince the FDA to approve it and patients to take it, especially with its high rate of manageable but unpleasant side effects. On a personal note, I received JCAR014, which is very, very closely related to the Liso-cel, and enjoyed a 5.5-year remission, clearly worth 1 month of misery from CRS and neurological events. Everybody will respond differently, but for me it was an amazing choice of therapy. If the numbers achieving a complete remission can climb, perhaps by adding a BTK inhibitor to enhance T cell function, I think CAR T could become even a stronger option for those with very few good choices. On the website, we give a link to the actual ICML abstract, Lisocabtagene Maraleucel, Liso-cel, in relapsed refractory chronic lymphocytic leukemia, CLL, small lymphocytic lymphoma, primary analysis of the Transcend CLL004. Thanks for listening. Stay strong. We are all in this together.